Now it's my pleasure to introduce our speakers, Dr. Matt Angelidis. He's the co-medical director for the Colorado Springs Fire Department and AMR, and is an emergency physician for UCHealth at Memorial Central, Memorial North, and Pikes Peak Regional Hospital. Also with him is James McLaughlin. He's director of Community Paramedicine at UPass Regional Health Service District. And with that, gentlemen, the floor is yours.
Good morning, everyone. Thank you for that excellent introduction. As Jeff mentioned, I'm Matt Angelidis. I'm an emergency medicine physician and EMS medical director here in Colorado Springs, and I'm joined by...
This is James McLaughlin with UPass Regional Health Service District, and I'm the director of the Community Paramedicine program. We cover 539 square miles of mostly rural and forest area, about 30 miles west of Colorado Springs.
So with that introduction, guys, what I would like to do is kind of present to you a summary of a problem. So as the COVID-19 pandemic has stricken our nation, we in the emergency medicine and pre-hospital world were faced with a new set of problems and a new set of tasks to try and provide efficient and appropriate safe medical care for our patients. In addition to that, around the same time that COVID-19 began to take hold of our country, programs like ET3 were put into place by CMS that allow EMS agencies to bill, code, and collect for alternate destinations. One of the premier alternate destinations that we envisioned in our community was telehealth or telemedicine, a fantastic solution for both the COVID problem and as an alternate destination for ET3. To summarize this concept, we know that about a third of the patients that dial 911 don't actually require emergent intervention, treatment, or transport to an emergency department. We also know that roughly 1 in 5 patients that utilize 911 are repeat callers. They've already been evaluated, treated, or taken to an emergency department. And then lastly, kind of bringing that or tying that back into COVID-19, we know that most patients that develop COVID-19 don't require emergency department treatment, 911 or EMS response or transport. And in most systems across the country, we know that when a patient calls 911, that invariably ends with the patient being transported to emergency department. So in our community, as we were sort of a later developer of COVID-19, we got to watch what happened in Italy and Europe and then subsequently New York. We had time to think about, is there a better answer, or do we have an alternate way that we can take care of these patients and deliver care?
So about February of this year, we started to see what COVID-19 was doing around the world. And one of the unique things about my position is I get to be imaginative in processes and imaginative in what we're going to do as an organization with the limited resources we have to address the challenges in our rural community. And that doesn't occur in an isolation. It doesn't occur as one agency. It's one of the cool things about community paramedicine is you identify your partners and you bring them all together and we work collaboratively to address the problem. So we started anticipating, we started looking at other areas and the challenges they were facing as COVID-19 ran through their communities. And one of the things we knew we had to do was improve transport efficiency. We knew that utilizing the most expensive form of transport to the most expensive destination every single time was not going to be a viable solution. We also knew that we stood the potential of losing a great portion of our workforce to the virus, either through this or through them being quarantined and things of that nature. So we wanted to reduce provider risk of exposure. We also wanted to expand access to care because we knew that the number one reason that patients don't receive health care is because they don't have access to health care. And that's either because they don't have insurance or because they don't have a primary care doctor, or they don't, in our area, a lot of times it's because they don't have transportation. And so we wanted to make sure that they had that expanded access to care. We also wanted to enhance the patient care experience. We wanted to make sure that patients had a unique experience we are a special district, which means we're tax-based, and we want to make sure that our community felt the value of the services that we provided and really saw the value in supporting their community partner, their community entity, us. And then we also saw that with our current workforce, we run 3 ambulances and cover 539 square miles, and there was no way we were going to be able to meet the potential demand of COVID without coming up with a unique and interesting way to address it. And so what we found is through this approach, we were able to take these ambulances and we could split up a crew and have one crew member run one call while another crew member runs another call, and it becomes a force multiplier for us. And we can take one ambulance and double the output of that crew.
So I'm going to walk you guys through sort of a case-based introduction to our solution to COVID-19 and telemedicine in our community. We're going to kind of highlight our approach, exactly what we do from a documentation, billing, and coding perspective, the software platforms that we're using to achieve these goals. We're going to specifically talk about Pulsera, our sponsor today, and why they're a unique solution to this problem. And then I'm going to talk, and James is going to talk a little bit about the future, how we can leverage this solution for COVID-19 into other avenues of healthcare. So we're going to start off with our case. As we develop the system in response to COVID-19, we're going to go through a COVID-19 case. Most of our calls are initiated via 911. So in this scenario, we're going to have a 64-year-old female who has a fever and a cough. Perhaps she has a known relative who tested positive to COVID, and she's worried that she may have COVID-19. So she has initiated a 911 call, and our PSAPs are dispatching that call to UPass Regional Health Services District. And our UPass Regional Health Service District EMS provider will get the notification from 911 along with the patient's identification, information, address, and phone number, and they will initiate a telehealth consult with this patient. This is done in one of 2 avenues. So if the patient has a smartphone or a tablet or a computer, they can receive a text message like you see on the right side of the slide here that instructs them to click on a link to create their telehealth portal or their telehealth visit. So our EMS provider has created a case in Pulsera, and they have notified the patient. Now, a lot of people will ask, well, most elderly folks don't have a tablet or a computer. It turns out that that's not the case, even in our very rural community. But occasionally we do have internet connection or phone problems, and so we can also dial in directly to a landline and initiate this visit before arrival over the phone. All through the Pulsera app. So you can do the telehealth face-to-face visit video, or you can just use a basic phone connection that connects with your patient. And so our paramedic here that you see in the big screen is connected with our patient that you see in the top right. This is into the classic video connection through Pulsera. This may also just be voice, as I said before. And they can attain an initial impression, and they can do a little preparation before they arrive. So we are concerned that this is a potential COVID-19 patient. And so our paramedics have the opportunity to instruct the patient to place a mask on themselves, to wash their hands, perhaps to move to a part of the house that they don't typically cohabitate in. So they may be asked to meet them on the front porch or in a garage or a utility room, in a place in the home that isn't, developed a high viral load or viral titer. So sort of prepping for the arrival of EMS before they even get there.
And then once we arrive at the home, like Matt said, we're going to meet them in an area with a low viral load that's safe for the patient and safe for the provider. And then once we're there, we're going to introduce ourselves, obtain permission from the patient to assess and provide care. And in this case, we're going to assume that the vital signs are all within normal limits and there's no remarkable findings in the secondary examination. You'll notice on the right side, there's a triage tool. And this is the tool that we utilize for any emerging infectious disease patient. And that's just the terminology we use to identify potential COVID patient. But this could be any other future emerging infectious disease as well. And we're going to ask the series of questions. On the left, you'll see the guideline, and we'll ask a series of questions to stratify the patient into one of three categories. They'll either be green, yellow, or red. And if the patient stratifies in the red risk category, and these are basic, mostly physiological criteria, so abnormal blood pressure, abnormal mentation, poor vital signs, poor blood pressure, things like that, those patients will benefit from immediate transport to the emergency room. So we don't delay care, and we transport them immediately to the emergency room in that situation. It should also be noted that there is real potential here to eventually turn this into a tool where we could alternatively designate them as a direct admit patient and bypass the emergency room altogether. And ultimately, that is our goal. But we have to have solid proof of concept first. So the next step is yellow priority patients. And if they fall into that yellow priority, then those patients need a telehealth visit, where we team up with the physician and we do the telehealth visit. And then finally, we have the green category where they're stable, their vitals are stable, they have no high risk criteria. And so these patients are going to be okay to stay at home without a telehealth visit, but they will need some follow-up, and they're going to need some social support. So we're going to get them set up with a safety net with Health and Human Services, make sure that they can get food and things of that nature. And both of these client sets, because we've teamed up with public health, both of these client sets will actually also get a COVID-19 sample collection and testing completed right there in their home. So we'll complete the test and then send that off to the state lab for evaluation and then get back to them with results in a timely manner.
Okay, so James went through a patient, and in our case, let's say that she selects him as yellow. So we would like to initiate a telehealth or virtual visit. There's a couple of key documentation things that have to occur in order to generate a billable encounter and to meet HIPAA and CMS requirements. So in your handout series attached to this presentation, we actually included the documents that we utilize here in our community, but our EMS agency has a consent form for a telehealth visit. The physician group, my group, emergency medical specialist, has a consent form for the telehealth physician portion of the visit. We also have a billing disclosure or a billing document capture consent form. This is interestingly also included in your attachments, but this is interestingly was a big hurdle initially for us because as ER docs and EMS providers, we're not used to talking to patients about cost and billing. But with a little training and education and a relatively straightforward form, we're able to communicate clearly with the patient the cost associated with the telehealth visit as opposed to the cost associated with transport and an ER visit. The patient will sign this form. Additionally, all of these forms are then photographed. So Pulsera, as a unique communication solution, is able to take HIPAA-compliant photographs, and these are then loaded into the patient encounter within Pulsera. Additionally, what we will do is have James complete a full history of present illness and physical exam. So on the right side of your screen here, you'll see a basic paper T-sheet. James or our community paramedic team will fill out this entire form and also take a photograph of this and load it into the Pulsera HIPAA-compliant platform.
You will also be provided a copy of this in the handout that you received related to this online training today. And I want you to notice in that middle section, there's some psychosocial questions and some questions about social history. And typically speaking, in a traditional 911 paramedic call, this is not information that we would gather. So this includes social history such as smoking history, drinking history, risk exposure, do you have a safe place to live? We utilize a tool called the SBIRT, or Screening, Brief Intervention, and Referral to Treatment, to identify risk for substance use disorder, depression, and suicidal thoughts. And then we also do some risk stratification for pediatric patients around immunizations and things of that nature. The reason we do this on these calls is a lot of these patients aren't going to be going to the emergency room. And so they lose that safety net that they sometimes would have in the emergency room. And so we wanted to maintain that safety net to identify patients who are at high risk for suicidality and substance use disorder, so that we could still navigate them to definitive intervention for those issues as well.
So in the background, there's a physician who is on call for telehealth consults for the day, dedicated to that as their sole duty for the day. And that physician will now need to be activated or let know that there is a patient that needs to be seen. James can click a button within Pulsera that will ping me on my cell phone, and I can log into the cell phone and take a look at all the documents that James has uploaded. So I can see the patient's vital signs, I can look at the history of present illness and physical exam form that he completed. James may also have done things like load an EKG if the patient had some chest pain with their cough, or he may have gotten a blood sugar or a D-stick for me if the patient's a known diabetic. All of this healthcare data is within the Pulsera app, and as I am pinged by James, I can log into the patient encounter. I'm added to the patient care team, and I can view all the records that James has obtained before he has consulted me. So what you see on the right side of the screen here is what it looks like on my cell phone. I get a little Pulsera blurb that pops up. It makes a rather annoying noise that lets me know I have some work to do. And then on the left side of the screen there is me getting my alert. And then I click a button within the app, and I'm now connected with James, or my community paramedic. So you see James in the center of the screen, and me in the top right-hand corner, and we are now engaged in a telehealth visit.
So one of the unique things about this program is it really creates an amazing partnership between the community paramedics and the physician partners. We really get to know each other really well, and we interact very effectively with one another. And that's been such a cool side effect of this program.
So James and I will now work together for me to evaluate the patient. I have my own T-sheet or paper document that I complete as part of the physician telehealth billing record. It also will be photographed and loaded into the Pulsera encounter. We may work together to have James do a specific physical exam finding for me. I can watch him examine the patient's abdomen, or I can request that he listen to heart sounds, check capillary refill, examine the lower extremities for edema. So he can be physically present, performing physical exam under my direct supervision and observation. So as a team, we evaluate the patient, make sure that I have all the information that I need in order to help make decisions for that patient's care. At the closure of the case, so in our example here, we have collected a COVID-19 specimen, which James and our community paramedics will take to the lab. And perhaps we have scheduled the patient an outpatient follow-up with their primary care provider in 24 hours. Or maybe we've agreed that James and the community paramedics will come back tomorrow to reassess the patient. In any regard, we've completed our telehealth evaluation of the patient within Pulsera, and all the documents are now photographed and loaded into the software program. And then we export this to our billing and coding company. This is a simple single PDF file that contains all the discrete data points, start time and end time for length of telehealth visit, the vital signs, the physician and paramedic history of present illness and physical exam forms, and then a brief medical decision making that I document on my form, as well as a disposition. Interestingly, through Pulsera, you can integrate these directly into your EMR. We are not currently doing this in our system, but you can generate a link that will load the documentation into, for example, an Epic encounter or an Epic software system platform, so that all members of the care team can see the information that was generated during the telehealth visit.
And you could do the same thing from the EMS side, which is absolutely fantastic. You can upload it into ESO or Image Trend or Zoll billing, whichever product you use. Because it's a standard PDF form, you can upload it into any of those EMRs.
So the next thing I kind of want to do is give a little homage to our sponsor today, Pulsera. And I'm just going to work through kind of why we utilize them as our solution here in Colorado Springs. The first thing is that for those of you who aren't familiar with Pulsera, it's a pre-hospital communication platform that's used nationally, most historically for patient communication around high-risk events. So like ST elevation, MIs, we can utilize Pulsera to transmit EKGs, to activate cath labs, to communicate to the ER that a patient's coming. And in our healthcare system and community, we utilize Pulsera universally across almost all of our EMS agencies and hospitals. So it is a platform that our medics and paramedics were already very familiar with. They interface with it on a daily basis. They utilize it to communicate stroke care, trauma care, STEMI care to our hospitals and subspecialists. The second thing is that, it's a HIPAA-compliant platform. So we are able to communicate healthcare communication and data in a HIPAA-compliant fashion for our patients in our system. And then lastly, when we started looking at how can we bill and collect under the future of ET3, and as telehealth has expanded its scope and billing process, Pulsera generates a very nice billable document that we can transmit to our coding and billing companies. So it sort of met all the needs of our community to integrate into a telehealth platform.
And so as we look at ways to integrate or ways to utilize this product, like we've talked about already, we're able to use it with 911 calls that come through PSAP centers. But I think that's the tip of the iceberg here, and the not so distant future. When I say that, I'm talking in the next, before the end of the year, we'd really like to start utilizing this to support other aspects of our business model. And that includes direct hospital referrals. So think about patients that are being discharged from the hospital that are at high risk. These are the patients that we see every single day that we're taking back to the hospital because there was something lost in that transition in care. And those transitions in care from the hospital home or from the skilled nursing facility home, those are when the patient's at greatest risk for dying and having bad outcomes. So if we can integrate that so that a community paramedic comes and visits that patient when they're discharged from the hospital, and we can power that with a visit, a teamed partnership with a telehealth physician, we're really increasing the power available and that program. So think about a patient who's released for a hip fracture or a patient who's released because of a recent stroke. Now we're going to come into the house. We're going to do a fall risk assessment because falls are the number one reason that patients bounce back. We're going to make sure that they got the medications that they were supposed to get upon discharge. We're going to make sure that they understand how to take those medications and the risks and benefits associated with those medications. We're also going to make sure that that the oxygen was delivered that they were supposed to have, so that all those aspects are in place and the patient understands their discharge instructions. Because when a patient's released from the hospital, more often than not, all they hear is blah, 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 you get to go home. Then they get home and they're faced with this stark new reality that is, I'm home, I'm alone, and I have no one. We want to be that someone. We want to be that support so that we can help them make sense of their discharge instructions and be part of the team that makes them successful. We empower them to be successful upon their discharge.
We also have partnered with skilled nursing facilities and long-term care facilities. We already have contracts in place with some local facilities here in the Springs that will enable to initiate a Pulsera physician telehealth visit rather than transport patients directly to the hospital. And as you can imagine, in a group living situation, if COVID-19 is the concern, a telehealth visit before transport could be very helpful in helping to prevent spread and transmission of the infection. And then we're also looking at how do we do emergency department follow-up or urgent care follow-up. So a CHF patient, for example, that gets diuresed in the ER and goes home with a home oxygen script and a new script for Lasix, it would be fantastic to have a Pulsera-initiated telehealth visit the next morning, making sure that they got their oxygen, their diuretics, their cardiology follow-up is scheduled. So we see this telehealth connection through EMS and community paramedicine as sort of the tip of the iceberg here with regards to expansion. So we already walked through most of this on a prior slide. The concept here is that Pulsera is already used in our community, so it's easy to adapt to a telehealth model. It definitely meets our HIPAA requirements, our billing requirements. And interestingly, we're going to talk to you a little bit about how we can utilize it to connect other parts of the team.
And one of the cool things about switching to or using Pulsera for this is, as Matt said, our providers were already comfortable with it. They were already familiar with it. And when you're asking them to do so many new things, so many different things, having a tool that they're comfortable with and that they're familiar with goes a long ways towards adding comfort and instilling some confidence in your providers. So the important thing to understand about a project like this is it doesn't exist in a vacuum, and anybody who started a new program or a new project in their community can attest to this. This is done only through a collaborative partnership. To ensure long-term success, you have to make sure that the local physicians are involved, the primary care providers, the ED physicians, all your local specialists, and then also your social services and your social support programs, such as Department of Human Resources, Teller County, or in our case, it was Teller County Public Health, and then our OEM, our Office of Emergency Management. And we've made sure that by tying DHS and Teller County Public Health and the Senior Coalition into this project, that we were able to provide complete wraparound services. Because it's one thing to come into somebody's home and just provide care, and then say, hey, good luck. I hope everything works out for you. By the way, stay in your house for 14 days and don't leave for any reason, right? It's a totally different thing to say, we're going to need you to stay in your home for the next 14 days, but don't worry because DHS is going to be contacting you in the next few days to get you set up with food and other supports that you need. If you need anything before they contact you, here's a direct number to reach out to them. They're going to be familiar with your case, and they're going to be familiar with what's going on. So by tying that in together, we can make sure that we're treating the whole person and not just the patient. And we call that the biopsychosocial model of medicine. We're treating the physiological aspects, the emotional aspects, and the spiritual aspects of the patient's needs.
Okay, so we've touched on this a little bit, but I kind of want to go through where do we see the future of this telehealth platform and as it connects with EMS and community paramedicine. I tend to personally focus on the transitions of care, and we've touched on some of that briefly. Patients that are discharged from the ER to home or from the hospital after an admission, patients that are in a skilled nursing facility and may be transitioning to an urgent care ER. We can leverage the Pulsera platform and this telehealth platform that we developed for COVID to provide needs for all kinds of transitions of care scenarios. Obviously, our fundamental goal in utilizing the telehealth platform is that we can reduce the risk associated with these transitions of care, improve communication and the patient experience. We can expand this telehealth platform to the 911 PSAP tiered response model. So we said at the beginning of this presentation, roughly 30% of 911 calls don't require emergency department care or transport. It would be fantastic to tier patients under certain guidelines and criteria into a telehealth Pulsera visit as opposed to a 911 physical response. We certainly see the future of ET3 and billing. We were fortunate enough to have Teller County and UPass selected as an ET3 demo location and our AMR Colorado Springs units, but we have a way to bill and collect for alternate destinations under ET3, and we can leverage this process that we developed with COVID and Pulsera to a multitude of other telehealth platforms. And then obviously we talked about integrating more with hospital discharge planning. We certainly see a cost savings benefit to preventing bounce backs or readmissions. So the potential is huge for the expansion of this telehealth platform in our community.
So, and when you talk about partnerships, it's going to be increasingly important as we move forward to become the value option in our community. And what that means is the payers see us as a value because we're reducing unnecessary transports but also our other partners see us as a value in our ability to get them time-sensitive information so that they can better manage their patient populations. And in doing so, we'll be able to utilize other specialties such as orthopedics, cardiology, geriatrics, and pulmonary and pulmonology. And we are already utilizing this very same concept to address the very complicated patient population that is behavioral health crisis and medication-assisted treatment or substance use disorder crisis patients. So what we're doing right now with this very same technology is we are able to arrive on scene for patients in behavioral crisis, de-escalate the crisis, medically clear them on scene utilizing an evidence-based tool, and then alternatively destinate them safely to destinations such as inpatient behavioral health facilities, community crisis stabilization units, walk-in clinics, and even get them set up with outpatient services such as behavioral health and medication-assisted treatment. This has been an amazing tool for our community, and in the time that we've been doing this, we've seen over $3.2 million in downstream cost savings by alternatively destinating patients to definitive intervention.
So, in summary, I believe that COVID-19 has sparked our community paramedics and hospital systems to meet the quadruple aim. We're leveraging this technology to improve the provider's experience, to improve the patient's experience, to improve population health, and as James just pointed out, to reduce the total cost or healthcare burden cost in our community.
So, as a leader of your organization, and I believe everybody has an opportunity to be a leader within their organization, as a leader of your organization, I would ask that you ask yourself these questions openly and honestly. Is your organization ready? Do you have the tools and partners identified? Do you know who you're going to need to work with? Do you know what equipment you're going to need? Do you know how you're going to get that equipment? Have you set the expectations and prepared your workforce? I mean, do you understand what your vision is and what your community's needs are? Have you done a community needs assessment? Do you know where the healthcare weaknesses are in your community and where you're the value option for those needs in your community? And then have you set that expectation for your workforce? Have you set that vision out there so you know where you're headed? You may not get there today, you may not get there tomorrow, but do they know where your organization is headed? Do they see that vision? And then have you prepared them with the education and training that they need? Have you offered them community paramedic courses? Are there community paramedic courses offered in your community? Does your state have a community paramedic program? What does that look like? And if the answer is no, if you're not there, then I promise you there's another agency or another entity that is going to get there. We know this because as we were building our program, we had multiple home health care agencies reach out and say, well, if they can't provide this service, can we? So if you're not going to be that value option in your community, I promise you someone else will. And that's not where we want to go.
So at this point, I'm going to turn the lecture back over to our moderators. James and I obviously are available to answer any questions. We appreciate everyone's time. We're excited about the future of community paramedicine and telehealth, and we look forward to continuing to grow and learn.
Yes, thank you both. Once again, this is Jeff Frankel, the GEMS managing editor. That was a great presentation, very informative. We have many questions lined up. Let me pull up what we have. Is this interaction recorded, and is it able to be downloaded and attached to the PCR?
So at present, we do not record the video interaction. I'll defer to our Pulsera team on the future of that plan and process, but presently we do not record the actual video telehealth portion.
With the technology that currently exists, with certain pieces of hardware, you do have the ability to do that and attach that as a separate form, but your organization will have to decide whether or not that's a valuable tool for you.
That was a great addition there. I was just going to say, hi, this is Hannah. I'm the Director of Marketing at Pulsera, and that recording of video is certainly something that is high up on our roadmap and will be coming available soon. Thanks for the question.
Another question. They say they want to present this program to their EMS and hospital networks. These groups are more used to being siloed. What advice do you have in regards to connecting these different but interconnected care systems?
So I know in our community, the driving force was some of the certification bodies like the AHA for STEMI certifications and the ASA for stroke certifications. They have quite a bit of mandatory reporting and databases in order to meet those certifications. And so we leveraged our subspecialty lines and we showed them how Pulsera could improve care in their silo. And so by sort of demonstrating proof of concept in some of those silos, we were able to broaden Pulsera to the larger community. So I think from my personal experience, when we had our entire cardiovascular service line on board with being able to track door to EKG times and door to balloon times and all these reportables that Pulsera really makes fantastically easy to collect and track. It was an easy sell in terms of getting those silos to support it. We've done the same thing with our stroke care service line, and now with trauma. You know, we're a level 1 trauma center here, so we have all kinds of trackables that are required, and Pulsera makes those things very easy and particularly connects the pre-hospital side of that to the hospital side of it.
Okay, great. And I guess this will be another question for Hannah. It seems that Pulsera is rural. The focus is rural. What about metro areas?
Yeah, absolutely. So Pulsera is flexible and scalable from large communities to your tiniest rural communities. So, for example, we're actually deployed across entire states, and then we also have small rural access hospitals using Pulsera up in Alaska. So, yes, we are used in rural and metropolitan areas all across the United States. There's no limit to the size of community or region, small or large, that can use it.
While we have initiated the telehealth COVID system in our rural community, UPass Regional Health Service District, we utilize it in the city of Colorado Springs, so nearly 1 million person city and suburb. So certainly works in the urban setting as well.
Okay, great. And how about when a patient is transported to the hospital? Is the data captured and sent there as well?
Yeah, so you can generate your teams within Pulsera, and they are able to capture and see that data. An example would be in our STEMI alert or stroke alert process, the patient's EKG, when the Pulsera STEMI encounter is activated, is viewable by our cardiology and cath lab teams. It's not uncommon for patients to spend less than a minute in our emergency department before going to the cath lab, or in some circumstances, a cardiologist is able to look at an EKG and de-escalate and say, no, we're not, this isn't a STEMI. We're going to evaluate the patient in the ER for an alternate reason for their EKG abnormalities. So the communication does extend into the hospital and into those individual silos like the cardiology service lines or neurology service lines.
And just to build on that, one of the really cool things from the paramedic side is that if we have a telehealth visit that then transfers or changes into a transport to the ED, that whole record can then be turned and all that information is pushed to the emergency department through Pulsera. And we don't have to then go and repeat the same information to the ED on the way in. They'll have all of that information already, which decreases the workload on the paramedic side and ensures that the same information is being shared across all the disciplines.
And can you elaborate on a statement about splitting the crew to handle 2 calls at once?
Absolutely. So we use ACT cars, or what we call alternative care transport vehicles, as part of our community paramedic program. And while our approach utilizes community paramedics and all of our paramedics are cross-trained as community paramedics, I feel like this program could be offered in a limited capacity, not through a community paramedic program. So if you didn't have the ability to invest in an entire community paramedic program, you could certainly use well-trained paramedics for this same approach on a standard 911 call. And so what we do is we have a community paramedic that's on 7 days a week from 8 a.m. to 8 p.m. But after those hours, or if a second or third call comes in, then we rely on one of our 3 911 ambulances to provide that second or third call. So what it allows us to do is the first community paramedic goes out on a COVID or what we call an EADS positive call. We can then send that second community paramedic off of the ambulance to take that second EADS call, and that keeps that third paramedic from that same ambulance available to take a third call. And that still keeps our additional 2 ambulances in service ready to go, and we're handling 3 911 calls all at the same time. If transport's necessary, then we can send one of our EMTs with that paramedic that's on scene to then transport that patient to the hospital. But more often than not, this becomes a force multiplier and allows us to literally double the amount of work we're able to do with an existing workforce.
Another question is, given the 911 call processing time constraints required for agency accreditation, do you have any suggestions or for triage to identify appropriate patients?
Yeah, so the national accrediting body for PSAP centers, and the name, I'm drawing a blank on the name right now. It's a bunch of initials, and they're an amazing organization. They actually have a protocol that they designed for pandemics. It's called Protocol 36, and it's adaptive to each community's available resources, which is great. And then the PSAP or the dispatch center with their medical director can kind of adapt those questions under Protocol 36 to make sure they're getting the information that they need. And what's really cool about that is it ties right into ET3 and the nurse triage line. So if it gets to a point where your available resources are completely depleted, then that medical director can actually turn on the next step of Protocol 36 and actually activate a triage line utilizing nursing triage or things of that nature. And while we never had to use it, we were actually able to take that Protocol 36 and adapt it in a way that if it ever had to be activated, we actually had it going out to not only nurse triage, but then the next step, we were actually utilizing paramedics that were at the station or paramedics that were off duty that would actually receive those calls on their personal devices as they were pushed from the PSAP out to be triaged. And that was all done in combination with Verizon and with Pulsera. So it's such a powerful tool, and Protocol 36 allows you to maximize all your available resources to still make sure patients are getting services in what could be the worst case scenario. Like I said, we never got to that point, but Protocol 36 allows you to do that and to grow and to change, much like the disaster system grows and changes with the disaster itself. This protocol grows and changes with the pandemic.
And another question is, will the app communicate with VS sensors like ECG?
The app itself does not contain or directly communicate with our monitors. That information is just physically put in by the paramedics. So they'll arrive on scene, obtain a set of vitals, and then they just punch it into the app. I will defer to Pulsera. I'm not aware of direct connection to the monitors, but there may be something out there that we're not using.
Yeah, thanks. So Pulsera does have a public API for integrations, which allows information to be shared in real time. Some of our integrations currently include the Zoll monitor and CT imaging in the hospitals. Our data is also NEMSIS formatted, which allows for bidirectional flow into EPCRs. But if there is an integration that anyone on the call is interested in hearing more about, just go ahead and reach out to us here at Pulsera, and we can go ahead and answer that question for you.
How quickly can EMS teams adopt something like this? Does it take very long to set up and learn? They want something fast, intuitive that can help the crews work smarter together and for the patients.
Yeah, so to answer the first portion of that, how quickly can an EMS crew adopt the software program and process? I would say that the app is very intuitive and very easy to use. We have had new hires literally go through a 1-hour course on the app and how to integrate with it, and they are effectively utilizing it to activate STEMIs, strokes, and even participate in our COVID Community Paramedicine telehealth program. So I think from an education perspective, the Pulsera team has incredible resources, online videos, in-person training, virtual training, and I think that it's a very intuitive software program that takes very little time for them to learn and understand and use and operate. On the back side, from the physician side, we have a team of docs that take telehealth call, most of whom are ER docs and don't have any experience participating in virtual or telehealth. And they were good to go and utilizing the software to complete a visit with less than an hour of training and education. So I think from a deployment perspective, it does require some training. You do have to play around in the app with the Pulsera team, but it seems to be easily adopted by the users. And we've had patients in their 60s and 70s utilize the app on their smart devices with little to no difficulty. I mean, a text message that has an arrow for them to click and then they're in, it is very, very user-friendly.
And the next question, I want to know how telehealth is used with a 911 call through a PSAP. Is it an RN or other provider that talks to the patient?
Yeah, so when we utilize this feature, it's generally while a crew is responding to the call. So one person will be driving. If we have a crew of 2, that's the only time we will use this because we don't want our providers driving and talking on the cell phone at the same time. So if it's a single provider, they may reach out to the client before they start en route to the call, if it's a lower priority call. And if it's a high priority call, then they may not utilize this feature. But if there's 2 people headed to the call or it's a lower priority call, then one provider who's not driving will activate this process and reach out to the client. And the important thing to understand here is we're not providing pre-arrival instructions. That's already been done by the PSAP, and we don't want to interfere with that because that's pretty important. What we want to do is gather additional information and provide the client with additional information to prepare for our arrival to make things safer, such as the assessment and then also sample collection for the COVID-19 test. So, but it also helps us understand early, in talking to the patient and seeing the patient especially, how is their work of breathing? How is their general demeanor, their mentation? Is this a patient that's absolutely appropriate, or is this a patient that we should probably just get an ambulance started to right away? We don't want to delay that ambulance if it's necessary. So it's just an added stopgap to make sure that all the processes we have in place are working effectively.
And an important question I know everyone wants to know is, how do we handle reimbursement for the EMS side? Do you have an agreement set up with the provider that does the billing?
So from the EMS side, I'll answer the EMS side, and then I'll have Matt answer the physician side. From the EMS side, we've done a couple of things. First of all, we sit in a unique position because we are a Colorado special district. We're a health service district. So we collect both a property tax and a sales tax in our community. And we see this as an opportunity to extend the value of the services that we provide. And then for people who live in districts, they are provided a discount. But as I've said early on, if there's no margin, there's no mission. We can't possibly do this work unless we're at least breaking even. And so what we do to make sure that we're doing that is we do bill the insurance companies. Right now, most of the insurance companies aren't paying for it, but we do bill them because we want to be on their radar. We're having those conversations with them, and we feel the best way to do that is to continually remind them through billing that we're there. We're very upfront with the patients ahead of time that their insurance company may not cover it. And so what we do is we understand that not everybody's in the same financial situation. And so we bill a maximum. If we're going to bill cash, we bill a maximum charge, and it's a nominal charge. And then we send that bill to them, but it's based on their ability to pay. We utilize the sliding fee scale that's set by our state through HIPAA, which is the Medicaid arm for the state. And so we go up to 240% and a bill on a sliding scale downward from there.
I want to thank all the viewers for participating today, and I want to thank our sponsor, Pulsera, for the support. Thanks so much, everyone. We look forward to seeing you back for another webcast soon.